So let's try to remember what's the action of the alpha adrenergic receptor in our body. You remember that for the alpha adrenergic receptor, we have two subtypes. We have the alpha 1 and the alpha 2. In order for us to recognize what would the antagonist do, it's very important to know what's the normal function of these receptors. So you remember, where are the alpha 1 present? مين متذكر معي؟ الالفا 1 receptors موجودين بالبلد فيسلز اكثر شيء. وين بالبلد فيسلز؟ بالفاسكولار smooth muscle cells of the resistant blood vessels. Activation of the alpha 1 receptors in the blood vessel lead to vasoconstriction. So if you remember again what we talked about previously, alpha 1 is a G protein coupled receptor. It's coupled to the GQ subunit. والجي كيو subunit معناها تفعيلها رح يؤدي ل increase in the calcium levels in the cell, and this will eventually result in muscle contraction. If I'm talking about vascular smooth muscle cell contraction, this will lead to constriction of the blood vessel. So how will this affect our cardiovascular system? بدي تعرفوا معلومة حكي عنها أكثر السنة القادمة إن شاء الله بالcardiovascular system، إنه ال blood pressure in our body is controlled by two main parameters. First one, اللي هو cardiac output, how much blood is coming out of the heart. And this is a term we call cardiac output. The second determinant of our blood pressure is the peripheral vascular resistance. شو peripheral vascular resistance؟ يعني ممانعة الأوعية الدموية. كل ما كان blood vessel constricted, when the blood vessels are constricted, we're going to have increase in the peripheral vascular resistance. When the blood vessel is dilated, we're going to have a decrease in the peripheral vascular resistance. So, the more peripheral vascular resistance I have, or more blood vessel constriction, I'm going to have a high blood pressure, okay? So, what would be the effect of antagonizing these alpha 1 receptors in the blood vessels? We're going to prevent the constriction, so we're going to have dilation, right? What's going to happen to the peripheral vascular resistance if I have dilation? It's going to be decreased. So what's going to happen to the blood pressure? It's going to be decreased. So these receptor blockers blocking of the alpha 1 receptor in arterioles will lead to vasodilation, leading to lowering of the peripheral vascular resistance and lowering of the blood pressure. What about the veins? Also in the veins, we have the alpha 1 receptors. Lowering of them will lead to dilation of the veins, lowering of the blood pressure. Lowering of the blood pressure, especially in the veins, lead to something called post-steroid hypotension. شو يعني hypotension؟ hypotension انخفاض ضغط الدم, lowering of the blood pressure. ليه بنسميه مرات post-steroid hypotension؟ شو يعني post-steroid؟ post-steroid وضعية الإنسان, right? So if I change my posture, sometimes, maybe it happens for some people, or to you sometimes, you're laying down and you suddenly stand up. This will usually result in changing in the blood pressure. Then the blood is pooling in the vein when you're laying down or if you are sitting down. And when you suddenly stand up, the body doesn't have to accommodate for this change in posture. So it results in something called postural hypotension. And this happens also with the use of vasodilators, which are the drugs that dilate the blood vessels. And what happens to us إذا لا سمح الله عمر حدا صابه الحالة إنه هيك قام فجأة وصار عنده عرض، شو بصير؟ بدوخ. شو كمان بحس بقلبه؟ اكسرت بدوخ. هاي بسبب الهايبوتنشن. حدا عمره مر عليه شيء مصطلح اسمه تسارع في نبضات القلب tachycardia. If somebody experienced that, he's gonna have something we call reflex tachycardia. شو يعني reflex tachycardia؟ Tachycardia is what we call increase in the heart rate. Reflux, it happens as a reflex of our body to this change in the blood pressure. We have certain receptors in our blood vessels. We call these the baroreceptors. The baroreceptors, they detect any change in the blood pressure. So if the blood pressure goes down, these baroreceptors, they're going to say, okay, the blood pressure went down, there's something wrong, I need to fix that. So they go ahead and stimulate nerves to activate the sympathetic nervous system. So what will the sympathetic nervous system do to our heart? What kind of receptors we have in the heart? مين متذكر شو الريسبتورز للادرينرجيك سيستم او الادرينالين in the heart؟ beta 1. Once adrenaline or noradrenaline binds to these receptors, what happens to the heart? بيزيد الهارت rate, بيزيد heart contractility. So if we have an increase in the heart rate, it's going to lead to tachycardia, and this is how these patients develop reflex tachycardia when they have lowering of their blood pressure, or where they have something we call again postural hypertension. Okay. So this is about the alpha-1 receptor. But we also have the alpha-2 receptor in our body. Where are the alpha-2 receptors located? Excellent. Presynaptic nerve terminal. Here. So these are the alpha-2 receptors. They're present in the sympathetic nerve, the nerve that's releasing norepinephrine, and their function is to control norepinephrine release. So this is normal sympathetic outflow. We have a stimulation of the sympathetic nerve, release of norepinephrine. Norepinephrine is going to go ahead and bind to its different receptors. We have alpha receptors here. And the body wants to regulate this signal. So one way to regulate it is that norepinephrine can bind to the alpha-2 receptor that's present presynaptically, and the alpha-2 receptor causes inhibition of further norepinephrine release. يعني هو بيعمل نوعا ما negative feedback mechanism on norepinephrine release. So what happens if I block the alpha-2 receptor? Excellent, Bijawab. Yes. As your colleague said, we're going to have an increase of norepinephrine release. I blocked the blocker. So if 2 negatives is equal to a positive. So again, I have a drug. My drug is an antagonist of alpha-2 receptors. They prevent norepinephrine from doing its action, which is activating the alpha-2 receptor. So prevention of the release will lead to more release of norepinephrine. So norepinephrine now is released in my body. Where is it going to go and bind? It's going to go and bind to all of its different receptors. Among these receptors, we just mentioned we have the beta-1 receptors in the heart. What is it going to do to the beta-1 receptors in the heart? It's going to activate them to cause tachycardia. So, what's the where am I leading to? If I block the two types of receptors, the alpha-1 and the alpha-2, I'm going to see more of the tachycardia than if I block the alpha-1 alone. Okay, if I block the alpha-1 alone, I'm going to see reflex tachycardia, as we see here in this first paragraph, that is related to the postural hypertension. The body responds to lowering of the blood pressure. If I block both the alpha-1 and the alpha-2, I would see the reflex tachycardia associated with the alpha-1 blockage, but also I would see more exaggerated tachycardia because I have now enhanced release of norepinephrine due to the blockage of the alpha-2 receptor. Okay? Now, other effects of the alpha-adrenergic receptors outside of the cardiovascular system. Remember, in the eye, we said the alpha-1 receptors, they cause contraction of the radial muscle of the eye, leading to mydriasis. So if I block that, I'm going to have narrowing of the pupil, which is something we call meiosis. With regards to the nasal congestion, it's a side effect of the drugs that are alpha blockers. Why? Remember last time we talked about phenylephrine being a drug that's used to treat nasal congestion because it causes constriction of the blood vessels in the nose that are blocking the airway. Now, if I block the alpha-1, you can have dilation in these nasal vasculature, so more congestion, and it's usually not a wanted effect, it's a side effect of the drugs that we use. كتير شغل الألفا-1. شغالين okay. 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 Another effect of the alpha adrenergic blockers is the decreased resistance to the outflow of the urine, and I'm gonna talk about it in a bit. So again, let's talk about the effects, the clinical effects of alpha adrenoceptor blockage. If I have a non-selective blocker, now I'm talking about drugs. الأول كنت أحكي general cancer. What would be the effect of them on the blood pressure? I'm blocking both the alpha 1 and the alpha 2. Okay, now, if I block the alpha 1, I'm going to have lowering of the peripheral vascular resistance due to the vasodilation, and then lowering of the blood pressure. So this might be useful as an antihypertensive drug, used for the treatment of hypertension, ارتفاع ضغط الدم. But if I have a non-selective drug that's going to block the alpha 1 and alpha 2, will it really have a clinical effect on lowering the blood pressure? Actually, not so much. Why? Because we said we block the alpha 1. Yes, we are having vasodilation in these blood vessels, but we block the alpha 2 and we activated the release of norepinephrine, which is going to go ahead and bind to the beta 1 receptors in the heart, increase the heart contractility and heart rate, increase something we call the cardiac output. حكينا قبل شوي, the blood pressure depends on the cardiac output and the peripheral vascular resistance, so we have now an increase in the cardiac output that's going to some extent balance out that vasodilatory effect. So non-selective alpha antagonists have limited beneficial effect on blood pressure reduction due to the associated alpha 2 blockage, which increase norepinephrine effects. اللي هو هلا حكينا, remember blockage of the negative feedback alpha 2 receptor will increase norepinephrine release, and this may cause increased beta 1 stimulation through tachycardia. So what about the drugs we have? We have 3 examples of drugs today for the alpha. Yeah. So let's start with the first one, phenoxybenzamine. Phenoxybenzamine is a non-selective antagonist of the alpha adrenergic receptors, although it has a slight preference for alpha 1. What's special about phenoxybenzamine? Phenoxybenzamine is an irreversible blocker, so it's going to take hours to days to see its effect, because it binds covalently to the receptor. What is it used for? It's used for pheochromocytoma. Sure, pheochromocytoma is something we're going to talk about in the endocrine system, but it is a tumor, a neuroendocrine tumor that happens in the adrenal medulla, and it's going to secrete what the medulla secretes. What does it secrete? Epinephrine and norepinephrine. So it's going to secrete large amounts of epinephrine and norepinephrine. So people who have this tumor, they're going to have signs and symptoms related to enhanced sympathetic activity. So they're going to have elevated heart rate, elevated blood pressure, headaches, weight loss, and elevated blood glucose. So because we are activating the different kinds of receptors of the sympathetic nervous system, it would make sense to use a non-selective blocker to reverse their effect. So one of the uses of phenoxybenzamine is the treatment of pheochromocytoma. Other uses, it's used to treat urinary obstruction. I'm going to explain that in further detail in a bit. Side effects, زي ما حكينا بشكل عام, كل non-selective drugs, they're going to have a side effect of orthostatic hypotension and nasal congestion. Phentolamine is the same mechanism, except that it's not a covalently bound drug, so it's a competitive antagonist. It is also non-selective. It has actually equal affinity for both the alpha 1 and the alpha 2. It is also used for pheochromocytoma. And we said these drugs that are not selective, we don't use them as antihypertensive. It's not a very good general antihypertensive drugs. I know we see lowering of the peripheral vascular resistance. We might sometimes see lowering of the blood pressure, but it's not reliable because, again, we said we have a stimulation of the beta 1 receptor causing reflex tachycardia and برضه stimulation of the sympathetic outflow. Due to this, هذا نفس الباترن اللي حكيته قبل شوي. We have noradrenaline released. They bind to its different receptor, but it needs to be regulated. One way to regulate it is norepinephrine or noradrenaline binding to the alpha 2 receptor and inhibiting the release of norepinephrine. If I use a non-selective blocker, this drug here, it's going to prevent the action of the alpha 2 receptor, prevent the inhibition, so more noradrenaline or norepinephrine release. Side effects, we have orthostatic hypotension, reflex, cardiac stimulation, and nasal congestion. Now we have different examples here about selective alpha 1 blockers. Yes.
بس ليش ما ذكرنا الريفلكس كاردياك ستيميليشن في الاول؟
الأول يعني هو موجود to some extent, but because we said it has a slight preference for the alpha 1, and we don't consider it pure. It's not a pure alpha 1, but it's not absolutely non-selective. Okay. Okay. The selective alpha 1 blockers, we have here 5 names: prazosin, alphazocin, doxazocin, tirazosin. المطلوب منكم تعرفوا يعني how they work as a general. يعني you can distinguish them from the zocin part, except for the last one, tamsulosin. Okay. All of these are selective alpha 1 blockers. They are used to treat hypertension, used in the treatment of chronic hypertension, as you can see here. But they are not our drug of choice for the treatment of hypertension. Inshallah, next year, the cardiovascular system, we're going to be talking about 10 groups of drugs for the treatment of hypertension. We're going to mention these, but as we go on throughout the lecture, you're going to find they're not used a lot. They are sometimes used if the patient does not respond to the first line treatment, second line treatments, then we can use these as an additive. لأنه في أحسن منهم. ليه؟ لأنه لهم بعض السايد افكتس. مع إنه هم نوعا ما their side effects are limited. اللي هي tachycardias we can control that. Inshallah, next year we'll talk about how we control that. But studies, or we'll postpone that for next year. Studies have found they're not very powerful in lowering the blood pressure or preventing cardiovascular diseases associated with hypertension. So what are they used for? They are used a lot. لما نطلع على الكلينيك الباطني تشوفوا كل المرضى الكبار بالعمر بياخذوا واحد من هاي الادويه، ليه بياخذوهم؟ بياخذوهم for something else. Why do these elderly patients take these drugs? They take them for the treatment of urinary retention in men who have a condition called benign prostate hyperplasia. شو هاي؟ اللي هي تضخم البروستات بتصير عندك بعد السن. So why is this related? This is related because if we remember where the alpha 1 receptors are present, محاضرة المرة الماضية, they are present in the sphincters in our body. We said when I am in a fight or flight position, do I want to worry about going to the bathroom? No. So one way to control that is we have constriction of the base of the bladder and constriction of here, of the muscles at the base of the bladder. It's called the intrusive muscle, and then the sphincter here, or the neck of the bladder gets constricted. How is it getting constricted? It's getting constricted by the action of the alpha 1 receptor. So, norepinephrine, ayuhon, is going to get released, it's going to bind to the alpha 1 receptor, and then it's going to lead to constriction. These men have this prostate that's enlarged, so it's causing pressure on the base of the bladder and on the urethra, making urination not very easy for these people. So you will hear them, they say, I have تقطع بالبول أو صعوبة بالتبول. Why is that? It's because of urinary retention associated with the benign prostate hyperplasia. So it's a symptom of benign prostate hyperplasia. So what do I use my drugs for? My drugs such as prazosin are inhibitors of the alpha 1 receptor. They're going to prevent the binding of norepinephrine, so less constriction, allowing more of the urine outflow. So it's used to treat the urinary retention associated with this condition. It doesn't treat the hyperplasia itself, it just treats the symptom of urinary retention. What would be a side effect that we would worry about? هذول الرجال كبار بالعمر عندهم هاي المشكلة عم بعطيهم دواء to make it easier for them to urinate. But what would be a major side effect I would be worried about? Excellent. hypotension. شو حكيت hypotension؟ لما انت بجوز بدوخ الواحد مريض كبير بالعمر we are scared that he might faint when he has lowering of the blood pressure. So what do? We advise those patients to start taking the drug at bedtime. When he wants to sleep in the bed, he's not going to go around and get subjected to this hypotension. As we said, it's postural hypotension. It occurs more when you change your position. And luckily, the body gets tolerated for this side effect. Yani, we said we have now a new drug coming to my body that's lowering the blood pressure. After a period of time, the body is now more resistant to the hypotension because tolerance developed to the side effect. So what do we call this term? The patient might suffer from hypotension during to exposure of the drug initially. It's called the first dose phenomena. First dose phenomena is any feature of prazosin and some other drugs used to treat hypertension. So in order for us to reduce the risk of fainting in these elderly patients, or any patient طبعا, but we said it's more common in elderly patients, we advise them to take the first pill or the first few days of the drug at bedtime until tolerance develops for the side effect. So what is prazosin? Again, it's a selective alpha-1 antagonist, mainly used as an antihypertensive, but this is its main indication, but it doesn't mean that it's the first choice as an antihypertensive. It doesn't have alpha-2 blockage, so we don't worry about exaggerated reflex tachycardia. We will see reflex tachycardia, but it's not activated or enhanced by the alpha-2 blockage. But we still worry about tachycardia for some extent, but it's less than non-selective drugs. It works by dilating arterial and venous slits, which lead to a lowering of the blood pressure by causing relaxation of both the arterial and venous smooth muscles. Another important indication, it improves urinary flow in patients who have benign prostatic hyperplasia. Another important thing I failed to mention, this is the prostate. There's also the alpha-1 receptor present in the vascular muscles of the prostate, and it can aid to the contraction or pressure that the prostate is causing. So if we inhibit the contraction of smooth muscles present within the tissue of the prostate, it also helps in relieving the pressure in these patients. Now, moving on to talk about the beta receptors. Beta receptors are very important in cardiovascular diseases. And the discovery of the beta blockers or the beta receptor antagonists was a revolution in pharmacology. Because as you will learn, inshallah, next year, beta blockers, which are beta antagonists or beta adrenergic antagonists, are used in quite almost all of the cardiovascular related diseases. شو الأمراض اللي يستعمل لعلاجها؟ I'm going to go back to these slides. So they are used as antihypertensives. They are used in treatment or prophylaxis of angina, They are used to treat ventricular and supraventricular arrhythmia. They are used in the prophylaxis of myocardial infarction. Myocardial infarction or angina, they are considered ischemic heart diseases. So they're used for the treatment and the prevention of ischemic heart diseases. We said cardiac arrhythmias, blood pressure, also heart failure. So 4 cardiovascular conditions that we will be discussing next year, beta blockers are involved in their treatment. In addition to that, they're used to treat migraine, or if we take them early on prophylactically for migraine. They treat thyrotoxicosis in hyperthyroidism. So they have a lot of use. Remember we talked about the discovery of them. I don't know if we talked a lot about it, but before the discovery of the alpha and beta adrenergic receptors, the general term that was dominant at that time. When was that? That was in 1948, the discovery. Before that, they thought that we have two different types of hormones. One of them we call it E, sympathetic, and we were talking about the sympathetic nervous system. Sympathetic E causes stimulation, excitatory, and sympathetic I causes inhibition, it's an inhibitory. And because we have these two different hormones or neurotransmitters, some muscles, such as, for example, we said vascular smooth muscles, get contracted, while other muscles, such as the bronchial smooth muscle, get relaxed. So we have two different hormones. There was a scientist called Raymond Alquist. He was doing some experiment to treat dysmenorrhea. To find a drug suitable for painful periods or menstrual cramping. So he noted that the drug he was giving for adrenaline, adrenaline in the uterus causes relaxation of the muscles of the uterus. But what does it do to the heart? It causes increase in the heart rate. So this is the same neurotransmitter or hormone. In one tissue of the body is causing contraction, while in another tissue of the body is causing relaxation. So he proposed his theory that was antagonizing everything that was known at the time, that we only have one hormone, but the difference is these two organs, and what they have is two different receptors. So we have only one neurotransmitter, and we're going to consider adrenaline and noradrenaline as one. But we have two different types of receptor. One of them, who we later found out to be beta 1 or beta 2, in the lungs we have the beta 2 that's causing relaxation, and in the heart the beta 1 causes contraction, and of course in the blood vessels we have the alpha 1. And this discovery laid the ground for the development of the beta blockers, which has just mentioned how important they are in treating an array of conditions that are major health problems nowadays. The number one killer worldwide is cardiovascular diseases. So you can see how much the development of beta blocker was revolutionary or important for the medicine. As you can see here in the 1960s, beta blockers were developed and were the earliest prototype beta blocker was called propranolol. هلا حنحكي شوي عن propranolol. So what are these drugs? These drugs occupy the beta receptors. They competitively inhibit the occupation of these receptors by catecholamines, norepinephrine and epinephrine. Now they have differences with regards to the lipophilicity, for example, and their ability to antagonize the different type of receptors. We're going to talk about selective and non-selective antagonists. And with regard to their lipophilicity, it's important to know that lipophilic beta blocker enters the central nervous system, so they will have effects centrally. They can be useful in the treatment of migraines, but sometimes they also have side effects related to their central nervous system inhibition. Now we have divided them into non-selective. So non-selective, they're gonna inhibit both the beta 1 and the beta 2. We have the father of them, the propranolol prototype. We have timolol and satolol. We have non-selective that can inhibit beta 1, beta 2, and alpha 1. We have carvedilol and labetalol. So هدول الأدوية, in addition to their effects on the beta adrenergic receptor, they inhibit the alpha 1. So they have vasodilatory effect. This helps us in the treatment of hypertension. And then we have the beta 1 selective, cardio-selective. ليه cardio-selective؟ لأنه احنا نعرف إنه البيتا 1 هو المين subtype that's present in the heart. So the non-selective drugs, what would be their effects on the body? عندنا هون أمثلة عليهم nadolol, indolol, propranolol, timolol. They block both the beta 1 and the beta 2. Usually, blocking the beta 2 receptor, if we're talking about cardiovascular condition, results more of the side effects of these drugs. So we don't prefer to use non-selective agents unless we have a certain indication for their use. So what are the effects of them? If I block the beta 1 receptor in the heart, I want you to know three new terms: inotropy, chronotropy, and dromotropy. مروا عليكم بالphysiology. So inotropy اللي هو strength. Inotropic agent, it increases the contractility of the heart. Chronotropic agent, chrono لها علاقة بالوقت. So it increases the heart rate. And then dromotropic, it's related to conduction. So what will the activation of the sympathetic nervous system to the beta-1 receptor do in the heart? It's going to increase inotropy, increase chronotropy, and increase dromotropy. So our drugs, the beta blockers, will have a negative inotropic effect, as we can see here. Negative chronotropic effect, negative inotropic, and negative dromotropic, and conduction becomes faster. Slower. The conduction becomes slower and we're inhibiting the dromotropic effect. We're not going to get into the detail of it, but it's an indication for its use in the treatment of cardiac arrhythmia. We said blockage of the beta-2 receptors results in side effects. Can I get in a bit? So what is their effect in the body? They affect the cardiovascular system. They lower the blood pressure. Just 1 minute. الو هلا انا محاضره عندي امتحان عندي محاضره Okay. So, what are the effects of these drugs on the cardiovascular system? They cause lowering of the blood pressure in the patients who have hypertension. هلا the mechanism of how they do so is multifactorial. كيف يعني في كثير اشياء متعدده تدخل فيها وحنحكي عنهم next year ان شاء الله. But let's try to work what we have. We said the blood pressure depends on two parameters. What are these? Cardiac output and total peripheral resistance. What happens to the cardiac output when I use a beta blocker? What did we say the effect on inotropy and chronotropy? Negative. So what's going to happen to the cardiac output? It's going to be decreased. So we have a negative inotropic effect on the heart, which results in reduction of the cardiac output, leading to lowering of the blood pressure. Sorry about that. The second mechanism, which is something we're going to discuss next year, inshallah, in further detail, which is something related to the renin-angiotensin system. You've learned about this system in physiology. So one of the receptors that stimulate the secretion of renin in our body is the beta-1 receptor. So if I activate the beta-1 receptor, I'm going to have more renin release. So if I block the adrenergic receptor, I'm going to have less renin release. So less activation of the renin-angiotensin aldosterone system. So what will this lead to? This will lead eventually, as we learn next year, inshallah, to lowering of the blood pressure. Also, it have a centrally mediated effect due to reduction of the sympathetic outflow from the central nervous system. So the lipophilic drugs that cross to the central nervous system, they're gonna inhibit centrally sympathetic release or flow. Now, what are other effects? Can have other effects of the cardiovascular system on the blood pressure? Other effects, the effect of the heart. We're not going to have tachycardia. We're going to have bradycardia. Bradycardia, lowering of the heart rate. We said also we have dromotropic effect. So it leads to slowing of the AV nodal conduction. يعني احنا بنعرف انه في عندنا atrioventricular, there's a conduction system between them. We learn next year inshallah the cardiovascular system. So we're gonna نقلل conduction. هذا slowing is going to be useful for us to treat certain types of arrhythmias. One type here specifically is called supraventricular arrhythmia. But don't worry about this type specifically, let's just know the general term, the beta blockers can be helpful or useful for the treatment of cardiac arrhythmias. Now on the respiratory system, what is their effect? What kind of, we're talking about non-selective blockers now. What kind of receptor do we have? بالbronchi lung.
Beta 2.
Beta 2. What's the effect of activating the beta 2 receptor?
Dilation.
Dilation. Excellent. So if I antagonize that, what's going to happen? Constriction. So we're going to see increased airway resistance, bronchoconstriction due to the blockage of the beta 2 receptors. This is a side effect. So can I use these drugs for the treatment of asthmatic patients? No. الناس اللي عندهم asthma, الناس اللي عندهم ربو, they have more prone to constriction. They have hyperreactive airways. So these hyperreactive airways, upon any stimuli, dust, cold, they get constricted. So usually they have these asthmatic attacks more often than a normal patient would have this constriction due to allergy. They have exaggerated reflux or response, بلاش reflux, exaggerated response to stimuli. So if I use a non-selective beta-adrenergic antagonist in these patients, I'm going to have more constriction. So it can be sometimes lethal in these patients, bottle use a lot of oxygen. So we never use a non-selective beta blocker for the treatment of asthmatic patients. In the eyes, there's a condition called glaucoma. رح ناخذها بالتفصيل يعني later on مش بهاي المادة بمواد ثانية. The beta receptors in the eye are responsible for production of a liquid called aqueous humorous. وهذا aqueous humorous بتجمع داخل anterior chamber of the eye. If we have increase in the level or the amount of this fluid, it's going to lead to more pressure, which is something we call glaucoma or open-angle glaucoma. So beta blockers are useful topically for the treatment of glaucoma because they can reduce the intraocular pressure by preventing or reducing the release of the aqueous humorous. ورح نحكي بتفاصيل أكثر عن glaucoma. This is not the only drug. There are other drugs. Maybe you talked about them مع دكتور يعقوب الcholinergic system. Maybe you talked about a drug called pyrophosphate. برضه هو يستعمل لعلاج الجلوكوما. Other effects, they have effects on lipolysis, glycogen lysis. Sometimes beta blockers increase the bad cholesterol in our body and they decrease the good cholesterol. This is an unwanted side effect that occurs in a number of patients, يعني مش كل المرضى, with chronic use of these agents. So we have to be careful about that. We talked about their uses. We explained the antihypertensive use. We talk about these uses more next year. اللي هم الأنجينا والأريثميا. Let's talk about this important fact. شو عندكم محاضرة بعديها؟
Community.
Okay, I'll try to finish up for الدكتورة مشكلة تيجي. متذكرين موضوع receptor upregulation, receptor downregulation. This is where it applies. Remember I gave this example for you at the beginning. We never ever stop treatment with a beta blocker abruptly. فجأة. ليه? Remember we said when I have an antagonist that's in my body for a long period of time, the body does not like this change, so it goes ahead and it upregulates the number of receptors or decreases the number of receptors. So this happens when I use beta blocker for the treatment of hypertension, for other cardiovascular disease, for chronic use. Now let's say this patient for any reason decided to stop the use of beta blocker. What happens to the body? Now we have a higher number of receptors or more sensitivity of these receptors. And we have a lot of catecholamines going on in my body. So these catecholamines are gonna be able to bind to this higher number or more sensitive receptor and they're gonna activate them more. This puts the risk on the heart of the patient. So when these drugs are to be discontinued, we should taper down the dose, gradually reduce the dose rather than suddenly withdrawing that to allow this number of receptors to go back to normal. Contraindications, we said we never use non-selective beta blockers for the patients who have asthma or the patients who have COPD, chronic obstructive pulmonary disease. We said they affect the carbohydrate metabolism, they affect insulin sensitivity, so we have to be watching out for diabetic patients. They are not absolutely contraindicated with diabetes. But we have to watch out for changes in their response to the antidiabetic treatment. Now, so what's the preferable choice? The preferable choice is to use the selective beta-1. We call them cardio-selective because we said the beta-1 is the one mainly in the heart. We have acebutolol, ismolol, and metoprolol. Let's talk about differences between two of them. Ismolol is a very short-acting drug, ultra short-acting, and it gets inactivated in our body within 10 minutes. So it's useful for the emergency treatment of certain conditions, cardiovascular conditions that we call supraventricular tachycardia or arrhythmias. Also, arrhythmias that are associated with thyrotoxicosis. So it's used only in the emergency setting. لأنه it works only for 10 minutes, so it needs to be IV infused, continually infused to give us its effect. Now, with drugs that have similar spectrum, it's also beta-1 adrenergic antagonist, هو metoprolol. Metoprolol يمكن أن يستعمل لفترات أطول. Its half-life is between 3 to 7 hours, so it's used as an antihypertensive. It's used to prevent from ischemic heart diseases. It doesn't, of course, have a lot of tendency for bronchoconstriction because of the selectivity of the beta-1 blocker. Lastly, labetalol and carvedilol, they are blockers for both the beta-1 and the beta-2, so they will lower the blood pressure. We said they're blockers also of the alpha-1, so they can have a vasodilatory effect. They are useful antihypertensive drugs. They can be useful for the treatment of pheochromocytoma, but usually they are given after the administration of an alpha-1 blocker. They are useful for the treatment of preeclampsia, or hypertension during pregnancy, because of their vasodilatory effect, so there is preservation of blood flow to the fetus. Okay, so I want you to know these important terms. They're also useful for heart failure لأنه they attenuate oxygen-free radical lipid peroxidation، يعني بيمنعوا الفري radicals which can damage the heart. بيعملوا inhibition للvascular smooth muscle cell mitogenesis، بيمنعوا الهايبرتروفي بيصير بالهارت بحالة الهارت failure. Okay? Thank you so much, and I have to go لأنه الدكتورة مشكا استنى برا تأخرت عليها. Again, if you have any questions, please contact me early on, not just right before the